All right, good afternoon, folks. Welcome to the session. So it's my great pleasure to introduce Dr. Anand Iyer. He's the Chief AI Officer at WellDoc. And Anand is actually an engineer by training. He received his PhD and MBA from Carnegie Mellon. And he spent his entire career at the intersection of technology, strategy, and regulatory policy in healthcare. He pioneered Blue Star, the first FDA-cleared digital therapeutic for type 2 diabetes, and this is something that is deeply personal to him, given that he lives with this as well. He co-founded the Digital Therapeutics Alliance, and today he leads AI and data strategy at WellDoc, navigating probably the hardest problem in health tech today, which is making AI that's not just smart and intelligent and does cool things, but also that is safe, regulated, and reimbursable. And that is, as many of you know, that's a challenge that a lot of our pilots face as well. So with that, welcome, Dr. Iyer.
When I give a presentation. So if the click is really bad, just tell me and I'll stop and I'll stand behind the podium. All right. So first of all, thanks for having me. I really appreciate doing this, and there's always so much to learn from dialogue, so I'm looking forward, Deepak, to the dialogue afterwards as well. But 30 seconds of context of who we are, and then you'll have a better sense of why I'm going to say the things I'm going to say. You said it correctly. I am a type 2 diabetes patient myself. I was in wireless consulting for, 2 decades, and then developed type 2 diabetes myself. So I joke, the two things that define me, one is wireless in my blood, one is too much sugar in my blood, and somehow WellDoc managed to fuse the two together. But when you think about a patient, and then by the way, it's not just diabetes, it's any chronic condition. You think about a patient who has one of these chronic conditions, they have to manage, I use the acronym MEDALS, which is M, medication, E, education, D, diet, A, activity, L, labs, S, symptoms. They have to manage 6 vectors of things throughout the day. And there's this small thing called life that gets in the way every now and then. At the same time, even if they were diligent about managing all of these things, what's their doctor going to do in a 5-minute office visit? The doctor doesn't have the time, nor do they have the insights that the data may be telling them. In fact, half the data may be even missing. A hemoglobin A1C is a nice number, but it's an average number. But if I'm doing this all day, blind coma, and they see a hemoglobin A1C of 7, they're like, great, come back and see me in 3 months. Meanwhile, I'm going to be the next one in the ER, right? And so we asked a very simple question. Could you intersect the patient at the point of care and provide them real-time coaching and feedback that guides them in a precise clinical manner? So if I have a blood sugar that's high and I'm on this drug regimen, metformin and Januvia, and somebody else has the same high blood sugar, but they're on Lantus and Apidra, how do you then correct that high blood sugar? The clinical pathway is a different pathway, which means you're crossing a boundary now into regulated medical device world, right? And then we said if we could take all the data that we were collecting, this rich, what they call PGHD, or patient-generated health data, and if we could run it through evidence-based and evidence-driven algorithms, AI algorithms, to then illuminate to the healthcare provider, hey, by the way, this is where your patient was, this is where they are, this is what's changed, and this is what you should do against evidence-based medicine, but you're the doctor, do what you think is right for your patient, right? If we just did those two things, could we effect a bend in the cost curve and in the outcomes curve? And what we saw was fascinating. So what we are is a AI-driven cardiometabolic health platform, and whilst we started in diabetes, today it's a set of conditions that you see here, where you're using all forms of AI, which we'll talk about, to actually help guide. I use the analogy of Google Maps. Turn here. Google Maps doesn't wait until you're 50 miles off course to correct you. Hey, if you can stay in the range that you're supposed to stay in, then you have a higher probability of success in terms of your outcomes. So that's kind of what we do, and we support both the patient and the provider, which is an exciting thing for us because people ask, are you trying to get rid of the doctor? We're like, no, absolutely not. But we're bringing them together and letting them stand on technology shoulders and AI shoulders, and they can reach further, right? So what do patients actually want? So I thought I'd start with this is kind of, recent surveys. What are they actually looking for when you ask them about AI? And you can see in the left chart, the concept of prediction That's fascinating to me as a data junkie. Don't you just want to see what happened? No, I want to see what's going to happen. So they're interested in prediction, and they're interested in prediction for some of these comorbid conditions, as you can see here. And you look at the bottom, right? It's diabetes, cancer, heart and cardiovascular are kind of the leading things, right? At the same time, if you look on the right, how willing would you be to use AI for the following healthcare services? This is actually interesting because a lot of them want personalized, tailored medication. Think about a person who's on insulin, right? And maybe in a combo of long-acting and short-acting insulin. How do you titrate? When do you titrate? And they're wearing a continuous glucose monitor that has a trend arrow that tells you a value every 5 minutes. Well, geez, that would be great if I could actually do something with that information. So they want that kind of support moment by moment, but they also want managing chronic conditions, and they want recommending treatments, which is fascinating because we're going to talk about this in a little more detail, the line between regulation and not regulation, right? So if you expand that beyond the patient and you start to look at the health systems and the physicians, you can kind of see this picture that I've drawn, and you can read the bullets faster than I can speak, but I'll summarize them on the right, which is people want improved personalization. You know this concept of large language models? We were just talking about the conference in New Delhi 3 weeks ago. 550,000 people showed up at Modi's conference, by the way. If you think that CES is a big show, it's not. Like, holy crap, 550,000 people, okay? And one of the most important discussions was small language models, like edge computing, okay? Small language models that don't require gigawatts and gigawatts and gigawatts, they'll be on your own device using your own data. People want personalization, right? At the same time, they want reduced cognitive overload. Don't give me all the data. Tell me what I need to do from the data, right? Just tell me what I need to do. Google Maps doesn't give you your lat-long coordinates it tells you, make a right turn, in 100 feet and then call it a day, right? You want the insights, so data, information, knowledge, action. You don't want the raw data. It's necessary. That's the first domino that needs to fall. But you need the action and intelligence. Doctors want to, of course, when you look at, we'll talk about the use cases, the number one use case today for physicians is note capture, automated note capture, which in some cases can be unregulated, clinical decision support. In some cases, it's actually regulated. I'll tell you where. But they want increased workflow efficiency, right? Because then they can spend more time doing what they were trained to do, which is provide empathetic care to their patients, right? And then, of course, at the enterprise level, you want to optimize all the things you want to optimize. Risk, you want to optimize your cost overlay, you want to optimize your clinical outcomes against all the quality measures like HEDIS, stars, et cetera, right? So at the end of the day, what our objective should be, collectively, our objective for AI should be to transform the care continuum. And that means transform it at every point that you see, from the left side of prevention all the way through to the right side of acute care, with everything in between. But you also want to shift this momentum towards the left. You want to be able to catch things earlier based on patterns that are observed. So here's a fun one. How many people, I shouldn't ask that question because you won't answer. It's not a fun question to ask. Everybody knows what a GLP-1 is. I was going to ask you how many people are on a GLP-1, but that's not a good question to ask. Yeah. How many, you all know what GLP-1s, right? And yes, because of recent administration moves, but also private industry moves, the prices are coming down, but it's still expensive. It's still an expensive drug, right? And at the same time, how do you know who should actually get it? Who should cover it? Well, I have a predictive algorithm, for example, that looks at the first 30 days of your metals engagement, and I'll tell you whether you're going to hit your weight loss objective with 93% accuracy in 6 months using that data. And you know what? Maybe for you, you don't need to be on a GLP-1. Just keep on doing what you're doing, great. But you know what? No amount of running around the block is going to help, right? You have to be on something that's going to help you, right? And so people want the ability to predict, which means you're working back towards prevention, which is a very fun concept, right? So AI, my God, I think it's one of the most misunderstood terms because everybody synonymizes AI with generative AI. So yes, I'm a Carnegie Mellon guy, yeah. So it's very near and dear to my heart. Alan Turing, 1956, teaching a machine to do what a human would otherwise do or think. That's the definition of AI. And it starts out with what we call rules engines or state vector machines. By the way, you know why a rules engine is so powerful? If glucose is this, and medication regimen is this, and reading type is this, and last meal is that, do X. The FDA loves that because it's traceable. It's traceable, which means I can do a risk FMEA analysis on that, and I can then tie it to an evidence-based guideline. Where did that rule in your logic come from? The problem, though, is it's static. It doesn't evolve. It's the same rule. And we all know that these diseases are fundamentally progressive. That's the way they are. So shouldn't it then make sense for the model to progress? Okay, maybe high-risk things are then managed through state vector machines. And then you introduce the notion of machine learning where you have the ability to adapt. In our case, one of the examples is how do you use machine learning to look, everybody knows what a CGM, like continuous glucose monitor, Abbott, Libre, Dexcom. Most people actually don't know what the shape means. Most primary care, and it's not a knock on primary care, they don't understand what the shape means. Endos do, because they're trained to, okay? So we have an algorithm that actually looks at the shape, and it first detects a shape of interest, and then it classifies it into 9 levels of severity. And then it provides coaching back to the member saying, hey, you know what? This was because of your, 2 slices of pizza that you had. Well, next time try to have 1, right? And maybe have 1 later on. You can still have your 2, but space them apart so your glucose doesn't spike, right? Machine learning algorithms, all the way through to deep learning, of course. This is for larger data sets, right? And then, of course, generative AI now, where generative AI, you're actually creating content, but you're also using GPT or transformer architectures to actually do mathematical modeling. The coolest one, which we have, that we just submitted to the FDA, is actually using a GPT model to predict the glucose value in the future every 5 minutes, 1 hour out, 2 hours out, and soon to be 4 hours out. We're trying to get to the 8 hours out. Why? Overnight hypoglycemia. If I can actually predict that in advance, how cool is that? By the way, it's half the error rate of what the sensor arrow shows you, which is really cool when you think about it, right? Again, what you can do with generative AI. So just remember, AI is all of these things. All right, this is fun because it shows how AI has evolved really with what's going on with the industry, but also what's going on with regulatory. And it just seems like, my God, this is moving so quickly, but ChatGPT came out in 2022. It was December 22, right? But yet, it's the most commoditized. Think about this. Computing has been around forever, the early 50s. But it didn't take off until the desktop PC was on somebody's workspace, okay? The internet, forget about Al Gore for a second. The internet has been around forever. But it didn't take off until Netscape. I'm dating myself. Netscape was on your browser, right? AI has been around forever too. Now it's democratized in the hands of every single person. What kid doesn't use GPT to write their college, essays and things like that? That's the way it is, right? Everybody has access to it, which is why you're seeing this rise in what's going on, right? So the question is, if I look at what's going on in AI space, I just looked 2 examples, which is Anthropic and OpenAI. Now they're focusing on health models or healthcare models, which is fascinating because now I was just with the Association of Diabetes Care and Education Specialists, ADSES, used to be the Diabetes Educator Association. Why would I ever go to a diabetes educator and ask questions? When I could just pull out my phone and say, hey, what are the 3 things I can do to help, what kind of exercise or what kind of diet or things like that. And so what we're seeing is that there's a trend, okay, where you have the commoditization of coaching. Okay, you have the commoditization of health coaching because I can just open my phone and I can ask whatever my favorite app is, and I can ask these questions, right? And what it's doing is it's collapsing, you see the bottom, the middle ground. Where you had well-established, there's wellness at the bottom. Above wellness, general wellness, there's class 1 medical devices, enforcement discretion, and class 1 medical devices. And you have class 2 medical devices, and of course you have class 3. What it's doing is it's taking out that kind of middle layer. the bottom layer is actually rising. Now, the bottom layer has a ceiling. At some point, we were talking about it. Today, I can actually go to Grok, okay, and I can actually say, I'm on this many units of Lantis at lunch, and and it'll tell me what to do. And I'm like, okay, that's interesting, because it's not a regulated medical device. By the way, the FDA is all over this. They're figuring out kind of catch up. But it's going to happen sooner or later. There's going to be that line is not going to move because it's patient safety risk. But things below the line, well, it's easy, right? It's general information and knowledge that you want to, right? So the way to think about AI then, and in the context of healthcare, whether it's chronic disease or it's general healthcare, is this kind of 2x2 matrix, which is I have one dimension of what's the intent of my AI? Am I using AI to actually drive operational efficiency? So it's going to do something for me that I already do today, but it's going to do it better, faster, cheaper. Okay? I'll give a couple of examples as we go through this. Or am I going to do something I couldn't even do before? So there's an area of novelty where the data when you look up in the nighttime sky and you see a point of light, and you're like, oh, it's a star or it's a planet. And then you look at that same point of light through the Webb telescope, and you're like, good God, it's 7 galaxies. AI to the physician is what the Webb telescope is to the astronomer. It lets them see things that are not visible by the naked eye. It lets them look beyond that patient, what they see in that 5-minute office, and oh, that's what you're struggling with? We can work on that. So people ask, will AI replace doctors? You go, hell no. But I really think that a doctor who uses AI may very well replace a doctor who doesn't. That's a fair way to look at it. It's an augmentative tool, right? So there's this operational efficiency or newness, and then, of course, is it high risk or low risk? So play it out. Lower quadrant, okay? I'm going to use operational efficiency and low risk. These are automation things. I mean, how effective is it for doing billing and claims management and things like that, right? Or mundane tasks that are repetitive where you have human error. Yesterday, I was at Holy Cross up the street here in Silver Spring, and it was an AI roundtable. At this end of the room, there's 2 orthopedic surgeons. At this end of the room, there were 2 radiologists. And the orthopod guy was actually pretty funny. And he's in the middle of the meeting, he goes, you know what? My colleagues over there, they're not going to have a job in a year. I'm like, okay, that's a nice thing to tell him, right? Literally. And this, of course, the radiologist gets up and he says, I've been hearing this story for 30 years, but, I'm still here, right? But think about it. Radiology, the machine reads it consistently. If I were to give the same scan to 6 different radiologists, I might get slightly different. There's a variation in what I might get back. The machine does it consistently. Now, I'm not telling the machine to diagnose anything, but the machine can be there as a supportive element, right? So think of automation, which is cool, but then if I want to use it for higher risk tasks, right? Like this diagnosis of a specific condition based on a scan or based on a signal, if you're detecting AFib, for example, in a heart failure patient, right? Those things are higher risk. Okay. AI, by the way, how many people always say human in the loop? Right? Raise your hand, come on, human in the loop. I would encourage us to stop saying that, especially in front of physicians. Call it AI in the loop. And they're like, oh, hey, yeah, that's better. So it's not replacing me. I'm like, no, it's helping you. It's the same concept. There's a loop. Whether you start here and go this way, you start here, go this way, it's the same thing, right? But messaging-wise, it's a positive message that it's not trying to eradicate you, but you can use it in high-risk situations. At the same time, there's all the newness. Imagine now, so we actually have the ability for somebody to say, hey, my hemoglobin A1C is 10, and I want it to be 7 in 180 days. What should I do? It's like Google Maps, you're in New York City and you set your destination as Washington, it gives you turn-by-turn instructions, and it'll create a cocktail of medals, medication options, education options, diet options, activity options, including sleep is a huge thing, right? Lab options, what you should measure when, and then of course how you track your symptoms along the way. But if you want to give precision medication guidance that's high risk. So this is an effective framework that allows us to partition the total value of what AI can do into these well-defined buckets. And of course, each bucket comes with its guardrails. Each bucket will come with its metrics, how you measure, what you measure. In some cases, accuracy, recall, F1 scores, AUC, ROCs may be very, very different than what it would be in another one where, yeah, it's general information, it's fine, right? So this is a good way to partition the space. We always tell our friends and our collaborators and our customers adopt this framework. And this is something the FDA is embracing as well because their dimension of risk it's pronounced, it's there, right? So here's a recent guidance document that came out from the FDA. How many people saw it? It came out like a couple of months ago maybe? January, yes, a couple of months ago. And what they did was they made clear what general wellness was, right? And what general wellness isn't. And you can see here, right, what's new. You can see the stuff on the left, but people can now use non-invasive sensors to estimate, but not use it to diagnose or treat. But if you want to do that, you're still held to the higher standard. You want to see clinical data, you want to see clinical results, you want to see patient safety risk analysis, things like that. And then you get cleared as the appropriate class device. But this was really good to hear from the FDA. And then, of course, on the clinical decision support, as long as you're using AI to help the healthcare provider, the licensed healthcare provider, okay, make sense of a patient's data, okay, that's an unregulated function. Because the clinician is what they call a learned intermediary. This is support that's going to them, and then they use their clinical judgment and their license. Yesterday, one of the funniest things that after these radiologists and the orthopedic surgeons were going at it of who's going to be around and who's not going to be around, the radiologist ended up by saying, I'll tell you why we're going to be around, is because you need somebody to sue, right? So we're not going anywhere. We all had a laugh over that, right? It's the honest truth. But this is great because we're seeing that clinical decision support. AI can illuminate so much more, right? It can do so much more to help the provider optimize the therapeutic pathway for that patient, which is fun. And then, maybe lastly, I wanted to share what's happening. How many folks are aware of what's going on with CMS Health Tech and the Access program? Any hands? Yeah, great. So this is the Dr. Oz, who's at the helm of this, Under Secretary Kennedy. And it is all about how do I, quote unquote, kill the clipboard, okay? How do I leverage highly scalable, highly cost-effective, but clinically validated digital health tools and AI to solve some of the biggest cost centers we have in the United States in our global, in our national public health initiatives. Diabetes and obesity are two of the front runners, right? And so the objective here is, if I have a Medicare patient, and I have a list of Medicare patients, maybe it's with an ACO, maybe it's with a Medicare Advantage plan, it could even be commercial, by the way, in the future. I have a list of patients, and the patient downloads the application that's gone through some certification, okay? So there's the Care Alliance Code of Conduct. There's also the DIME seal, the Digital Medicine Society seal. And then, of course, there's FDA clearance, which is a requirement to even have a DIME seal stamp of approval. They download the app, and then they invoke what's known as IAL2, which is the highest NIST level of authentication, clear, like the airport, ID.me, et cetera. And they use that token now to federate all their healthcare data over FHIR protocols. Oh, yeah, I see that your prescription data is at Walgreens, and I see that you're at Mass General with your EMR. Do you want to bring in your data to help fuel, okay, to help fuel the insights that you're going to get from your AI tool? And then on the back end, you have the ability to share your progress with a CMS-aligned network, i.e. back to the healthcare provider, the health system, et cetera. So this is fascinating because this program was conceived, they're flying the plane and building it at the same time, is the honest truth, but this program was conceived July of last year with the objective was the president came and kicked it off and said, I want to see this operational by July 4th, 2026, America 250, right? We presented our end-to-end solution on December 8th last year, which is fascinating. End-to-end, the whole thing. There it is, it works, right? And there's going to be another big hula April 8th or April 9th. They're trying to get everybody together for the early adopters. CMS is now telling the states, you don't have to do it, but hey, you should do it. And they just made $50 billion available in the Rural Health Transformation Program, okay, that gives each state $1 billion over a 5-year period. So they get, and it's use it or lose it. You get $200 million every year to do something. And it's fascinating because we're seeing for the first time this convergence of AI, digital, and legislation and government moves, which is powerful because that's how we're going to create scale and adoption of these things. So I just wanted to share these things with you, that at the end of the day, there is a massive, massive role, provided we do all the right things for governance, fairness, all the stuff that we should do. That's just part of discipline of building any AI system. But the opportunity for us to transform, and the opportunity for us to take cost out is absolutely dramatic. So thank you.
Fantastic.
Yeah.
Okay, I'm going to start the discussion, and then we're also open for questions. So please do line up if you have questions. That was exciting. I mean, I think the AI evangelizing to this community that you did it was really sorely needed. I think for a post-lunch talk, this was perfect. So I want to maybe sort of connect some of the things you've been saying to a lot of what the pilots do in this center, across the 3 centers. So a lot of the pilots are in the prediction space, as you pointed out, but also in the other parts, but particularly in the prediction space, and looking at a variety of different biomarkers, just to give a slice of it, right? So sleep, gait abnormalities, other aspects of behavior, and trying to predict, let's say, cognitive impairment ahead of time. And so I think just to think about their pain points, one of the pain points in many of these pilots is the reimbursement question, right? So that's always a pain point. So do they go, do they go sort of to the reimbursement through the regular pathways? Do they use the guide model? Do they go straight to senior living facilities? Do they go straight to consumer? And this wellness question also sort of plays on. So I'm just curious, like, what would be the right strategy for some of these?
You look at the back of my head. I used to have a lot more hair. It's been pulled out over the years. So real story, real experience. When we got our first FDA clearance back in 2010, it was the first of its kind to be cleared by the FDA. And we didn't know them and they didn't know us, but somehow we managed to get through and we did all the things we were supposed to do. We got our 510K. Fantastic. But they were a little worried. They're like, wait a minute. What if John uses Mary's account and gets Mary's amount of insulin and kills himself? And we're like, ooh, that's not going to happen. There's guardrails to avoid that. But we know how you think. So they insisted that we get an RX.
I see.
Okay, so we were the first RX. Lot of glass trophies in the kitchen. Software as a drug, blah, 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 okay? It was the dumbest model ever. Why? You just took something that was inherently scalable software and you now relegated it to a 1RX that depended on the doctor. So a couple of years after collecting more data, we went back to the FDA and said, do we really need this RX? They're like, show us your data. And by that time, we had already secured an NDC code. So here's the conundrum with software. You're getting drug-like benefits, but it's not a drug. Right. You can't, yeah?
Right.
We were the first and last to get an NDC code, by the way. You're getting device-like benefits, but it's not a HCPCS code, okay? And you know what? You're kind of like doing what the doctor is doing to help them, so it could be a CPT code, but you're not a doctor. You're not practicing medicine. So it's kind of square peg in a round hole. So when we went back with our data, they said, hey, actually, except for complex insulin management, everything you're doing is class 1 feature. We'll give you an OTC clearance. As soon as you get OTC clearance, you got a SaaS model. So now all of a sudden, I can go to a senior living assisted facility, I can go to a United Healthcare, I can go to a PBM, I go whoever I want to sell to, and it's a SaaS model. Where I need is we call it the Russian dolls model. I have the class 2 functionality nested within my class 1 shell. and there's an in-app upgrade and an in-app prescription capability that's then reimbursed. So I would say the way you should manage this is try to chase that SaaS model, because it's the most logical, and it fits under a different bucket of medical spend. There's usually budget there. Go that route, okay? And now with this access reimbursement that just published, if you haven't checked it out, go look at the CMS Access website, and it's got a rate card for these different conditions of what what's allowable, the payments that are allowable, and they've done it intelligently where it's partly fixed fee and partly value-based fee. So you get the value-based component if you hit this outcome, A1C delta, blood pressure delta, BMI delta, things like that. But that's what I would say is try to chase that SaaS model initially that makes more sense than trying to do square peg in a round hole.
I see. And in terms of, you mentioned the wellness angle, right? And so I'm curious as to what is the right strategy for pilots, right? Pursue wellness or go straight to FDA clearance. Part of it is you wonder whether wellness is just going to be, just so much out there that you may not be able to.
Well, you were saying it when we first met upstairs. The velocity of what's happening with Anthropic and with OpenAI and all these guys, it's nuts.
It's nuts.
And they're not throwing tens of millions of dollars. They're throwing billions of dollars at these LLMs, right? So there's a part of me that says, I think general wellness is going to be commoditized very soon.
That's right.
Very soon,
right.
If not already, okay? So then you're like, okay, I want to make general wellness a component of what I offer. Great. I'll have an API call to one of these engines, and I'll train it and put the guardrails and make sure that I'm not getting hallucinations. Fantastic. But I'm going to focus on my value, which is going to be above the line.
Right.
Medical regulated functionality,
right.
Where, the gentleman who was doing the foot insert today, fascinating but all of the presentations were amazing. That was really cool. Somebody in the judges asked a question. What are you going to do with this? How are you going to communicate back? And he had a good answer. I would have answered differently. I would have said, I have the data that I'm collecting, so I can either display it back to the patient, or I can display and notify. There's something I want you to notify you on. There's a pattern. Or I want to display, notify, and then coach. That's when the FDA gets involved, saying coaching is a class 2 function. And then I want to display, notify, coach, titrate. I'm going to do something with the med or something with something that requires another RX or whatever. That's what you can do with the member, right? That's what you can do with the patient. That's really cool.
Right.
Make sense?
Right. In a way, I think what you're saying is wellness sounds fantastic, but it does box you in potentially in the sense that, the compression due to, at least the perceived compression due to the way AI is advancing, could make it possible for everybody to come in. And just the velocity.
There was an interesting comment from one of the other physicians yesterday night, which is, is it just going to replace us? And then somebody else made the comment, hey, you know what? There's actually fewer people going into medicine. So 10 years from now, when the aging population is going to continue aging, there's going to be fewer. We already have a shortage. On a per capita basis. Yes, it's better than the WHO national average and all that. We still have a shortage, and it's going to get worse. So if AI can help do the lower risk stuff, then if I were a startup, I'm not going to compete against OpenAI or NVIDIA or Anthropic or Gemini these are, I'll figure out how to partner with them and how to create, for example, if I have a Azure Databricks cloud and I have a Databricks backend and I can bring those machine learning models directly into my Databricks backend, but then I can control them. So now my queries aren't going to the open internet, it's going to it's like a private LLM kind of thing.
The one caveat I would add is a lot of the pilots are developing or integrating data that is not necessarily within these big LLM spaces, right? So it's either the insole data or some other source of data, new sensors, what have you, and those are directions that are not what an LLM today does.
Nope.
Right?
And I think that's where they should focus on. And I'd be bold. Go above the line. Start to build your moat. Start to build that moat of regulatory prowess, whatever you want to call it, regulatory differentiation, because you're going to get the rest of the stuff for free.
Right.
All the other stuff is going to be there.
That's right.
Now collect that unique data and present it back in a manner that's going to change what the patient does, guide them in a journey to either straighten their back or walk with a different, whatever. I'm not a foot guy, so I'm making this up. But you know what I'm saying, right? Provide them that coaching against the podiatry guidelines or things like that.
Right. So the other angle of this is that, traditionally at least, if you are a 3-member startup or a small startup with a few people, by the time, just the amount of work and the money it takes to go through the regulatory pathway, to get the documentation, to write the code, to write the software, to get it in front of a senior living facility, to get the UI, it's just an enormous amount of effort. And at this point, a lot of that is compressed. So I am curious about, and I'm also curious, I don't know if you can talk about within WellDoc, the compression as well, but a compression as in what aspects of the work are things that you feel can be just quicker?
It used to take 2 to 3 weeks to even draft a human factors protocol. 62, whatever it is, 62, 3, 571 or 671 or whatever the number is. Now you do it in literally an hour, right? And then you recruit patients and you use social to recruit patients. So you can actually get your human factors protocol written, approved, implemented. You're talking a week instead of like the typical 6-month timeframes. I think there's a hell of an opportunity, even at small scale, limited resources. And many of you know Bakul Patel, who was Bakul was at CDRH. He's the guy who created Center of Excellence for Digital Health. Brilliant guy, dear friend. And Bakul would always say, FDA, it's not like we're asking 1,000 things more. If you're writing good software, you're probably following some CMMI level 3, 4, 5 process anyway. You're probably 62304 compliant. Well, we're just asking a couple of extra things. So it's actually quite doable, even for a small group of people, right? And now, it's not like this is new at the FDA. Kudos to them. The process is actually pretty straightforward. It's actually really straightforward. We have 11 510Ks on our solution today. It took us a year and a half for the first one.
Yeah.
It took us 2.5 weeks for the last one.
FDA is going to get it.
No. I'm telling you, the last one was a special, so it went through. It's 30 days, but it went through fast. We're moving in the right direction.
Right.
All of us, the ecosystem that will allow AI to flourish, we're all moving in the right direction.
And what stays? What is that stubborn human? What is that stubborn part that is simply not compressible or compressed? I'm curious.
I don't know, change management, right? I mean, good God, getting an organization to move this quickly. I'll give you a real example. Now you have coding agents.
Right.
Okay, nobody writes code anymore. Did you see that with the software computer science grads?
Let's not go there.
I know, it's like nobody's going to computer science anymore. And I remember my daughter's graduating biomedical engineering. She's like, Dad, I wanted to do computer science, and I'm glad she didn't. But you have coding agents, right? But now you have to train people on how to use these coding agents, and you have to incent them. You're not saying, I'm going to fire you, I'm going to use a AI. No. Instead of you doing this many lines of code in a month, you're going to do this many lines of code in a month. And so you're going to do more, you're going to reach further faster. I think training our people, training our staff, and it's the same for clinicians. How you bring AI capabilities right into medical school, literally right into medical school, and start there. Because the doctor of the future is not going to be foreign to these topics and concepts. When was the iPhone? When did iPhone come out? 07. 07. Yet we're in 26 today. So the iPhone age is 19. iPhone generation is 19. That means they're going to medical school in 3 years. Do you think they're going to want to graduate with a stethoscope that goes to-thump, when they can get an ECG on the back of our... I think there's an inevitability. I really do.
That said, I think the one question in this context is just a risk and liability, right? And so everywhere where AI has managed to do full automation, it's not just because you can generate the code, but also because you can verify it using AI, right? That loop where you can not just generate but verify, and if it's a bug fix, you can verify the bug fix, right? So that loop manages, has scaled, right? But if there is somebody who's responsible at the end of it, And you talked about computer science grads or other grads just using AI tools. Somebody has to read it. Somebody has to understand what's going on, right? So when there's liability at the end of it, I'm not sure what happens to just completely, fully depending on AI tools. Somebody has to actually understand it, and that work may be longer. or actually,
you're 100% right. I don't think we're there yet.
Yes.
I don't think we're there yet because the legal framework around us is still the old legal framework. I think that's going to be one of the next things that's going to be challenged in a very big way. For what areas and decisions will you let the liability fall on the AI versus for what situations will you need in this case, human in the loop, right?
Yes.
Right?
Yes.
That's a to be answered.
Yes.
Hasn't been answered yet. We're not there yet.
Excellent. So if there are any questions, please do line up. But let me ask. Yes, sure.
So this is fascinating. I think many of the awardees here, pilots here, one of the questions they ask is, how do I think about my revenue model strategy? And you sort of mentioned that a little bit. Maybe if you could reflect a little bit on WellDoc's journey, because I'm sure today's revenue model was very different from when you started out, right? So on the one hand, you can imagine that you start with something and you sort of pivot and you adapt as you go along, or you could be a little bit more deliberate and sort of plan it out, as you're thinking about the development of your own product. Can you talk a bit about that? Maybe for some of the pilots who
I think for sure. I think pivot. Don't be afraid to pivot. But pivoting means that your fundamental product architecture, your tech stack, etc., is pivotable also. Otherwise, you're going to rebuild everything. So, if there's one lesson to be learned, you're gonna pivot for your business model just because the business model is driven by forces that are not within your control. Right? Part of it regulatory, part market, part government, whatever. Okay. You should arm yourself with the maximum amount of flexibility by building an architecture that's flexible, that's configurable, that's scalable. And that's good software development practice. That's building in a platform mentality right from day one.
Right.
That if I need to configure and turn this off, turn this on, you should build it not monolithically, but you should build it in this agentic kind of interoperable.
And you could say the same thing with data too, right? If you depend on data, find a way to incorporate data that itself can also be flexible.
Absolutely. Your data architecture is so product architecture, platform architecture, data architecture, yeah, all three, yeah.
Great. I think we're at time. This has been fantastic. On that word of wisdom, I think we'll end. Thank you. Thank you, Anand.
Thank you.